Okay, next we are going to hear from Ms. Laura Holtz. She will be speaking to us about including vulnerable subjects with cognitive impairment in research. So it'll be a great segue from what Dr. Birdsong just spoke to us about. So Laura?
Thank you, Amy. Thank you all for staying. I appreciate, I understand it's the last day, but this programming has really set me up to be able to talk with you about a topic that's very passionate to me, both personally and professionally. So Dr. Birdsong just spoke with you about vulnerability, so we don't have to go through all those definitions. So yay for me, not having to go through all those slides. But what I'd like to do is start with a call to attention and hopefully a call to action when you go back to your own research organizations in whatever capacity that you're working in, to bring some awareness to a population that we, again, categorically often consider to be vulnerable, but maybe not in the ways that we are thinking about them. And maybe it can change your thoughts and your attitudes about how we approach older adults and those with cognitive impairment. So first, I'd like to start by introducing you to these two young, beautiful individuals. This is taken at their wedding picture, or their engagement picture, and these are my paternal grandparents, Virginia and Dorlin. So comforting to have them up here with me. So my grandmother was born in 1922. She was, with the exception of a bout of polio as a child, she was a very healthy individual. She did not have any cancer or life-limiting illnesses, and she lived to be 90 years old. And she and my grandfather lived together in the home that they built until he passed away just after their 50th wedding anniversary. And what I realized, he passed away when I was about 12 or 13 years old, but what I realized after I grew up and kind of knew a little bit more about what he had experienced at the end of his life, I found out that he was, in the early 90s, participated in an experimental treatment, which when they pulled out the documentation, I found out was a clinical trial for late-stage colon cancer. So I didn't know that research was going to be something that was throughout my entire life, even as early as age 12. But after his passing, my grandmother was very insistent that she stay in that family home. She wanted to stay in that home that they had built. And we wanted to honor that because it was her wishes. It was her preferred place for her death. And that's how we often joked about it, is that she was going to die there. And rightfully so, there were lots of wonderful family memories there. So she did remain in that home for a long time. And it was not until her mid-80s that the family started recognizing that maybe there was something going on. So none of my family lived close to my grandmother. We were all about 2 or 2.5 hours away by car, some of us as far as 10 hours away. So when we saw her, she looked to be functioning wonderfully in her own environment. But it wasn't until we started getting hints and clues that there might be something medically going on. So my grandmother got lost. She had been driving, going to the grocery store to get her daily or weekly supply of food, to continue to do all those normal everyday things. And she called us terrified. She was lost in a community that she had grown up in. And granted, it had changed in those 60 years that she had lived there, but she was lost. And that was the first clue for our family that something was going on. And after we started digging in, my grandmother was later diagnosed with Alzheimer's disease. And so then the family was challenged with many, many questions and many decisions. The first one being that we weren't going to be able to honor her to stay in that family home. She moved in with my aunt and uncle, and then into a nursing facility when the burdens of caregiving were too much, and later passed away in that nursing home. Gratefully, she passed away with her family around her in her home, be it a nursing home, but that was her home with family and loved ones around. So we're grateful for that very good death that she had, but it was not quite what we had promised. So then it comes to my career path. So as I alluded to, I didn't know what research was when I went into my career choice. Didn't know about this thing called clinical research, had no idea. What I started out as a high school English teacher, and I did that for several years. But later, after a move, because I moved mid-school year, didn't have a job, had to find a job, I was a young professional, went into project management. I figured it would tide me over for that next school year and that next hiring round. But what I realized was I really liked project management. It was actually pretty good at it. And so I became a clinical research coordinator, right? Project management, detail-oriented. I bring that teacher mentality to it. So when I'm doing informed consent, I really want you to know what you're doing. I'm teaching you about informed consent. But at that same time that I was a very inexperienced new coordinator, I was also a family caregiver. I was the only one in my family who knew anything about any medical situations. Now that I have this new title as a research coordinator, right? Your whole family think that you know everything about medicine because you're a coordinator. I was an English teacher, guys. I barely took science classes. But what happened is that I became the person that my family wanted to come to ask about some of these questions that we were having with my grandmother. I became our informal informant about dementia. Gratefully, I was working on a dementia study at that time. I was working on a late-stage dementia study with the patient and caregivers who were living in a community. And what were the challenges and burdens that they were facing? It was a pilot, so I only had about 20 patients. And we've recently started the randomized control trial on that study, and I'm very excited that we're now enrolling to see the efficacy about that study. So that study has brought me through my entire career so far in research. But I also do a nursing home study, trying to reduce avoidable hospitalizations at the end of life for patients whose home is the nursing home. And what I realized is my family was dealing with all of these questions. And so there is research that's needed on some of these behavioral questions. But as I started kind of looking around and coming to these conferences and asking others how they enroll older adults, especially those with cognitive impairment, especially those who have decision-making capacity issues, I was finding that we don't have a lot of experience with this population. And so was I doing something that was so novel or unique? Or what was happening there? And so I began to find out that we really have some questions to ask about enrolling older adults with cognitive impairment in research. And so Dr. Birdsong set me up great. We're going to talk about a vulnerable population, but not all of them are vulnerable. Not all older adults have cognitive impairment. Not all older adults with cognitive impairment may be vulnerable. So we need to look at that a little bit more. And we will do that about discussing including older adults in research. Second, we're going to look at the common rule. Dr. Lau set me up wonderfully on the first day to preview that with us, but she also talked about one thing that's passionate to me as well, and that's informed consent. How do we consent somebody who does have cognitive impairment? That sounds awfully scary. And then finally, let's talk about these ethical guidelines. How many of you have been in a talk this week that talked about the Malbot report and the 3 pillars of ethical research? Hopefully, perfect, everybody has. And I'm so encouraged by that because as we continue to talk about those ethical principles, it means that it's foundational to all of our thinking with research. If we're continuing to apply them and measure our decisions against them, then we're doing something right. And there they are, the pillars of the Belmont report. We will start with talking about justice and including older adults into the research program, and then talk about the beneficence. That pillar is a little bit more difficult to kind of decipher and figure out how we're going to do that and enroll these patients safely. And then finally, we're going to talk about that respect for persons and that informed consent that could often be kind of intimidating to include somebody who may not have decision-making capacity into your research. And I hope by the end that we all have realized that this call of action is not as scary as it may be perceived, but that we can do this, include older adults in our research. And frankly, it's a really untapped population that you may be able to increase those recruitment numbers that we often struggle to achieve. So, which one of these pictures could be your grandparents? Right? Everybody in this room knows or has an older adult in their life. So none of us are excluded from thinking about this population. And they're, not only are they in our lives, they're our loved ones and our family. And so thinking about older adults in research is an important topic. In addition to that, in the studies that we were looking at, one of the studies in the American Journal of American Geriatrics, let me get the title name right, in 2008, found that when looking at maximizing enrollment of older adults in research, they found in their studies that 76% of the older adults that they surveyed wanted to participate, but they weren't being given the opportunity to do so. And one of the quotes in that same article stated that if they had the opportunity to participate in research and find that cure for Alzheimer's disease and delirium, that it would be the most important thing that they ever did in their life. So this is not a population that is afraid to participate with us. They want to be approached. They want to be given the option to decide about research. But we're not doing that as a community. And so how can we change that? How can we approach that differently to tap into this population that really wants to be participating in our work? And then we go to the other side of this coin, is that we have diseases that are affecting older adults at alarming rates. And we are continuing to need therapies and need solutions to these devastating diseases. So this is taken from the 2019 Alzheimer's Association Facts and Figures infographic. And what it's showing us is Alzheimer's disease is the 6th leading cause of death in the United States. That is staggering to me. It's not cancer. Cancer's not one of those top ones, but Alzheimer's disease is 6th. 82% of people are going to be caregivers in their life. You may be caregiver for a child, but many, many, many of us are caregiving for our older generations. And it's important that we have the same resources available to those caregivers as we do to those pregnant mothers that we were talking about in the previous talk. There is some vulnerability there for our caregivers who are working with this population, and including them in our research as well to know their journey is important and part of the work that I'm doing. And then finally, 5.8 million Americans are living with Alzheimer's disease. And this is expected to increase to about 14 million in the next 30 years. So we have work to do, and there is no way to do this work unless we're enrolling those populations that have cognitive impairment. So we gotta figure out how to do that too. Not only do we have to find these cures, but we have to figure out how to bring those people in safely and ethically. So I stood back. My grandmother was not involved in a clinical trial. She was not one of those people who was involved in that early pilot, although I was able to kind of fill them in on what we were doing and help my family think about their actions based off of our pilot work, but she wasn't in one of those trials. And so I went on to clinicaltrials.gov, our repository of studies, to see what she may have qualified for, what she could have been included in if our family wanted to participate. And the numbers looked really good if I started looking at all studies and all studies that include older adults. Looks pretty good. Looks like there might be opportunity out there. But as I started whittling that down, I found that only about 1% of the studies are going to allow my grandmother to enroll if she has cognitive impairment. And she was pretty cognitively intact all the way up until several months before she passed away. So was that fair? Was that equitable? Did that meet the ethical paramount of justice? And I don't think it does. So I think we need to continue to reflect on what's happening in our environment and balance those against our ethical principles to ask those really tough questions. So then I said, okay, she was not going to be in those trials because they weren't available, but why? You know, I'm that kid who's like, but why did that happen? But why did that happen? So I went down that rabbit hole of asking why. So the first thing I found is that this disappearing subject idea is that people with cognitive impairment were just being excluded. So in this study that I'm profiling here, they found that just because you reached the age of 70, 20% of studies excluded you right off the bat. So once you hit the age of 70, they just don't even want to talk to you anymore. And that doesn't seem quite right. I think I'm still going to be able to participate when I'm 70, I hope. Then we go further, and what we start finding is a third of them were excluded just because they had cognitive impairment, with no justification on why that was an appropriate exclusion criteria. So now you take the 20% who've over age 70, and now you've got cognitive impairment, and that group's gone, excluded right off the bat. Well, and then 94 of them did not provide any justification on why we would exclude that population. So now we've excluded them, haven't even told them why they're not even being considered for participation. That was disheartening to me. And then, sorry guys. And for the reasons for exclusion, there were things that make sense if you're trying to protect for vulnerability. But the question is this up to us to protect on those? So the perception was that they were unable to follow the study protocols. Perception. We don't have hard facts that that's what was happening. There was a perception that there was concern about the data reliability, that they were unable to be informed, competent informants. Everybody? None of them would be able to? And then finally, physicians thought that they were helping to protect patients from risks and burdens that may be undue to their frail beings. I don't know about you, when I'm 70, I don't want to be considered a frail being. I want to have that autonomy to continue to choose. So, in the public dialogue, there are more and more attention to this issue, and I'm grateful for that. So now there's been the release of the inclusion across the lifespan from the NIH and this document from the FDA, which is calling to promote and include older adults in research. Sounds good, promote to include in adults. But there isn't that forced initiatives or forced actions for us to do that. So I think we need to take it upon ourselves to force us to do that. Ask ourselves the really hard questions of why are we not including them and how can we? And I think part of the reason that we have these barriers to including them is because the vulnerability question is a concern to us. We don't want to be including somebody who is perceived to be vulnerable that we may be doing undue harm to. But as Quincy alluded to, or it's explicitly stated in his conversation, just because you are a certain class or a certain category does not mean that you are automatically vulnerable. So just because you have cognitive impairment does not mean that you cannot make decisions. Actually, that's unlikely to be true. Many of the decisions that we're asking our patients to make may be minimal risk, and those types of decisions, if there's understanding, could be made by somebody who has cognitive impairment, even if they're scoring on some of the lowest quartiles of the mini mental status exam. So really looking on the patient-by-patient, subject-by-subject basis and talking with them may be what we need to do rather than excluding carte blanche. And again, we've talked about the common rule both in the beginning of this conference and now here at the end, that this clarification around vulnerable populations, looking specifically at the vulnerability to coercion and undue influence. And while our cognitively impaired subjects are called out, it's because there could be coercion, there could be undue influence, but we have an opportunity to mitigate some of that for our subjects. Some protections that we may want to consider are thinking about the risk level that are involved in the decision that we're asking that person to make. If we're concerned about their ability to make a decision, we first need to understand if they're capable of making a decision. Once that's been determined, and I implore you that our research assistants and our research coordinators, people like me, boots on the ground, we are able to make the determination if somebody is capable of making a decision. We have tools and techniques on how to do that. It requires training. It also requires empowerment of that staff to make those decisions. They know the subjects better than most PIs. So let's empower them to use those problem-making skills, use the information that they know about their subject, that they've invested so much time with them to make those determinations about capacity, and then to understand how to do that in an ethical and just way. We could also consider what safeguards do need to be in place if there are evidence that somebody may lack decision-making capacity. What can we do on our study teams? What can we do within the protocol to address that, rather than just excluding? And and rather than excluding them from the opportunities, the justice to participate. So now let's talk about those ethical guidelines, specifically with those with subjects with impaired capacity to consent. That respect for persons domain, the informed consent, we talk a lot about it. We've had a lot of talks this weekend about it, and I love hearing that because it really challenges us to go beyond that document, beyond those 40-page informed consents that can look really intimidating, to having a really robust conversation about them. What are the parts, the reasonable elements that people want to know from our informed consent? Let's respecting that autonomy for them to make a decision that's best for them. So I work in an urban environment where I understand the pressures of a recruiting thresholds. I understand that we need to recruit so many people to our trials. I understand the money that's lost when we don't. I'm on that side of the research. But what I don't advocate for is that we bring somebody in who isn't our right subject. It's not a right fit for them. It might not be the right fit for their life, right? They've got other priorities, especially thinking about my caregivers who are oftentimes caring for somebody with dementia and a young child. Can they realistically bring both, to attend to the needs of both of those people in their lives, bringing them to study visits that are often very burdensome to collect everybody and bring them with them to their homes or to the clinic from their homes. So really thinking about, does this fit for them? Are they informed about what the burdens are going to be with participation? So I like to put up this graphic when we think about decision-making capacity. It grows as we grow as children, as we start to learn about the world. But after we reach that point of autonomy, that age 18, that arbitrary age, we're assumed to have decision-making capacity and to be able to do it autonomously on our own. And as it wanes over our lifetime, that's when we need that protection. That's when we need that other caveat of the respect for persons. But it's not assumed that everybody's going to follow this diagram. Some of us may continue to have high decision-making capacity all the way to the end of our life. But some of us may have cognitive issues or may have decision-making capacity issues. So let's figure out the ways that we can use what we know in our literature to enroll those patients safely, to provide for their protection. And we know how to do that. If somebody's unable to provide informed consent for themselves, we do have the opportunity to use a legally authorized representative. And how do they make decisions? They make decisions based off of that person that they know so well. What were the patient's preferences? Did they talk about the want and the excitement, encouragement to participate? Did they document it in their living will? If not, what would they have wanted to do? What's that substituted judgment that we can apply for them? And then what's in their best interest? And what our studies have found is that the patients wanted surrogates, wanted their proxies to have autonomy to make those decisions. They weren't mad. They didn't disagree with the decisions that were made. They want us to be able to help them in this situation. So the next thing we need to think about is continuing to talk about strategies. Once we've identified that this isn't something we should be doing, tell me we can figure out how do we do it. So what are some of the strategies that we've learned in our experiences working with this population? And the first one I've learned is that teach back works. The AHRQ toolkit about health literacy goes into extensive detail about teach back. And ultimately, it's asking for people to restate in their own words that they understand. It's a great way for us to understand, do they understand what our informed consent say? So I think it actually not only can be used with this population, but any population. Next, we would need to empower our research staff who are on the ground to make these decisions. I know recruitment's very important, getting those numbers, but empowering them to say this isn't the right patient for this trial. They don't understand what they're agreeing to. They can't voluntarily agree. It's something that we get to stand up and advocate for our subjects. That documentation of informed consent regulatory requirement is a wonderful place to tell the stories of our patients. And if they can't consent, tell their narrative. honor that person that they are, and be able to document it so that we know, why did you exclude them? Was it arbitrary, or was there a really well-formulated reason for why we did that? Or the other hand, they have cognitive impairment and are able to make the determination on their own or with their legally authorized representative to help them to do that. And honoring that autonomy that we so value because of all those ethical principles that we continue to rely on. And finally, looking at inclusion and exclusion criteria. Can you defend it? Do you understand why the inclusion and exclusion criteria are involved in your study? And if you can't, who can we talk to about changing that? These need to be very well defined to the disease that you're studying. Should we be excluding people with multiple comorbidities from our trials if they don't impact the research that we're doing? Is that just? Is that respect for persons? Will they benefit from the risks and burdens there? And so finally, my grandmother was able to participate in my brother's wedding just months before she passed away. She didn't recognize any of us in that picture at that time. She did recognize me as the one who would always be smiling, and I'm great with that legacy. I'm happy about that because it's a positive way to be included in her life when she was very, very unhappy because of this disease that's very terrible. She was scared often, and that scared person wasn't the strong woman that I remember, but I'm proud to be her granddaughter. Thank you.